Good afternoon, everyone. So I know that some of us, I think, will be trickling in, but I wanted to give Dr. Bath enough time so that we can learn from her. So why don't we get started? So welcome to our UCLA CTSI Distinguished Speaker Series. My name is Jay Lee. I'm a professor in residence in the Department of Psychiatry and Biobehavioral Sciences. And here at DGSOM, I lead the Health Equity and Translational Social Science research team. So today I have this great honor to introduce one of my colleagues, Dr. Eraka Bath. So Dr. Eraka Bath is a professor of clinical psychiatry in the UCLA Division of Child and Adolescent Psychiatry. It is such a wonderful moment for me to introduce her. Personally, every time I have an interaction with Eraka, I learn something new. So today is no exception. So I look forward to learning another great things about her work. She also, within DGSOM, she serves as the vice chair for equity, justice, equity, diversity, and inclusion. I think personally, I think she's such a wonderful educator, wonderful mentor, and wonderful supervisor. So, and as you already may know, she's a champion of advancing health equity with particular interest in minoritized populations, including populations of foster care and juvenile justice-involved youth. Dr. Bath specializes in diagnostic assessment and forensic consultation with emphasis on high-risk youth, including those with histories of trauma, child welfare, and juvenile justice involvement. She has an impressive record of funding, including funding from NIH, NIDA, PCORI, and LA County Department of Probation. So today, I'm really excited to learn about, so she'll be sharing her thoughts about framing reproductive justice for girls who are involved in the juvenile, legal, and child welfare system. Again, it's such an honor to have Dr. Eraka Bath. On a personal note, such a wonderful colleague. She throws awesome parties. And I just want to, join me in welcoming Dr. Bath, and really excited to hear your talk.
Thank you, Jay, for such a great introduction. I'm embarrassed and flattered. Okay. So first, a land grant acknowledgement to honor ancestors past and present. And then I like to do something called call and response in the African tradition. So I'm going to ask the audience for their attention. So I'm going to say the word ago, and then you're going to respond ame, that you are listening. So we can try it. I don't know about it's probably the people on Zoom can't do it, but we'll do it in the audience here. So ago. All right. Yay. All right. We're doing tandem slide decks. Okay. And then I like to, these are my disclosures, which Dr. Lee shared some of my funding history, but I actually prefer to anchor my disclosures really in terms of my positionality and reflexivity, thinking about ways in which I have privilege, ways in which I experience marginalization, and how that brings me to the work that I do. So I identify with she, her pronouns as a Black, cisgender, heterosexual woman. I'm an African descendant of enslavement with Caribbean roots. I'm the granddaughter of a domestic worker and merchant seaman and mother to a teen daughter. I'm daughter of physician activist, second generation physician. I've been working in predominantly white institutions my entire academic career, and also working with youth in the juvenile legal and child welfare system since 2003. I'm an HBCU medical grad and an aspiring good trouble champion. These are some of my collaborators, and it makes sense to start with them and the acknowledgements. I'm grateful to be working closely with Dr. Elizabeth Barnard, Sarah Godoy, who is a PhD student at UNC Chapel Hill, a bevy of research assistants who keep me, they're like the academic glam squad, and lived experience experts whose pictures I cannot show. Okay, so relevant theoretical frameworks for this talk really today to anchor the discussion around working with youth who have juvenile legal system histories, child welfare histories, and also youth who have histories of commercial sexual exploitation. I'm going to talk about intersectionality, public health critical race praxis, racism as root cause, structural competency, which is pioneered by our own Dr. Helena Hansen, structural intersectionality, and reproductive justice. And so when we talk about intersectionality, it's really a lens or prism for seeing social and personal identities. And historically, people would think about their race, their gender identity as separate facets. But thanks to legal professor Kimberly Crenshaw, she really helped us think about the ways in which these identities are overlapping. And so often what is missing in a lot of our discussions is the confluence of identities and how they can amplify marginalization. So Audre Lorde says this best, says there's no such thing as a single issue struggle because we do not live single issue lives. So this framework of intersectionality is really key when we're thinking about youth who have child welfare connections or juvenile legal system connections. Next, thinking about public health critical race praxis and really sort of anchoring the discussion in contemporaneous race relations and historical things that are going on. So I am going to talk a little bit about Roe v. Wade because that's inextricably tied to the sexual and reproductive health outcomes of the patients I work with. I'm also going to think about who gets to produce knowledge, who's at the table. So some of the frameworks that I've also been using in my own research involve community partnered and participatory research frameworks. And so thinking about knowledge production, working closely with lived experience experts and sort of recentering those margins, that's key. And how do we measure success? And then action, what do we do? So how do we disseminate information and with who? Racism as root cause. So this is really key to really think about racism as an overarching structural driver and at the root of many of the inequities that we see. And so if you can answer yes to any of these questions, it's likely that the population you're working with have racism at the root cause that's a driver of their inequities. So barriers to wealth accumulation, educational inequities, a disproportionate burden of housing insecurity, disparate treatment and justice system, or disparities by skin tone and color, and youth who are child welfare impacted as well as juvenile legal system impacted have all of these features. Structural competency is very key in really sort of thinking about myself as a clinical person, as a person who is a researcher, and how I can sort of work outside of just the patient doctor dyad, and also outside of the research enterprise and think about policy relevant interventions. And so this really implores us to develop structural humility, but also language and skills that sort of work on structural drivers, because we have a lot of positionality as researchers. Next, structural intersectionality. So historically, intersectionality really focused on personal identifiers and social identifiers, but so many people who experience the confluence of marginalization are also overrepresented in structures that are oppressive. So thinking about intersectionality and these identifiers and then superimposing them on structures where we know that there is oppression that occurs, that's the sort of mashup, if you will, of structural intersectionality. And so thinking about macro structures and policies, right, where certain people who have the multiplicity of marginalized identities are overrepresented and laying on racial historical trauma can give us insights in how to address their health inequities. Okay. Now I'm going to go to reproductive justice. I want to make sure the video works, which it worked in our test. Where's Marco? They say it better than I can say it, so I do want to show it. Marco, the video. Oh.
Is this the slide?
No, it should be.
Not playing at all?
Mm-mm.
Let me try. Interesting.
We just played this.
can I go to
Yeah, you want to go to
YouTube?
YouTube? Yeah, it might be easier since we're. Okay, go to YouTube.
Let's see.
I'll be here.
Do you want to link it for?
Yeah.
How do I,
And I'll screen share. When you're ready.
okay, how do I do that?
Where is it?
Well, there's a link there, but
Right there.
you'll be less clumsy than me, I think.
Let's see what we can do here.
For years, the experiences of Black women, trans people, and non-binary people have been excluded in the fight for reproductive rights. The mainstream pro-choice movement has failed to address that there is no choice, or there is no access. By focusing on abortion rights alone, advocacy ignores the barriers marginalized folks face when trying to access things like safe abortions, contraception, and sex education. In 1994, a group of Black women coined the term reproductive justice. When they noticed there was little mention of health services like pre and postnatal care, fibroid screenings, or STI testing in healthcare reform, and little understanding of how things like income, housing, and the criminal justice system affect Black women's reproductive choices. They recognized that the women's rights movement, dominated and led by middle-class, wealthy white women, could not represent the needs of women of color and other marginalized people, and called for an intersectional approach to reproductive health care. The argument that abortion is an individual decision flattens the problem into a binary, pro-choice versus pro-life. Intersectionality reveals how multiple systems of oppression work together and limit access to reproductive options for Black women and other marginalized groups. Since our arrival in the United States, Black women have been targets of reproductive oppression, from being worked and bred like animals to being forcibly tested on like lab mice. Our bodies have been controlled inhumanly for centuries. In the 1900s, a new strain of racism emerged called eugenics, a pseudoscience devoted to proving white racial superiority, which led to the forced sterilization of many women of color. Between 1970 and 1980, sterilization cases rose from 200,000 to 700,000. Teaching hospitals across the South routinely performed unnecessary hysterectomies on poor Black women. In 1973, Minnie Lee and Mary Alice Rull were just 12 and 14 years old when they were sterilized without consent under a federally funded program. As you can see, Black women's reproduction has historically been viewed as negative. To this day, Black maternal mortality rates are the highest of any racial or ethnic group in the country, with many Black women reporting being dismissed when complaining about extreme pain. The effects of these types of injustices are felt for generations. And with bans like the Hyde Amendment and the Family Act directly impacting people already facing systemic barriers to care, they continue to be ignored. The current conversation is focused on the stripping of rights afforded under Roe v. Wade, but for many Black and poor people around the country, these rights have never been actualized. Black women-led reproductive justice organizations like Sister Song, Ancient Song Doula Services, Black Women's Health Imperative, and others have been fighting to keep women of color and trans and non-binary people's voices at the forefront of the movement. It's time we shift the conversation to what needs to change and address the social, political, and economic inequalities impacting a woman's ability to access reproductive health care. It's not enough for abortion to remain legal. In order to truly have reproductive justice, we need to address all the issues involved. To learn more and take action, visit liberatedbodies.org.
Thank you. Okay, so we learned a little bit about this, and I think working with the youth that I've been fortunate to work with, their reproductive and sexual outcomes really have been ignored and really out of the purview of the systems that are serving them. And so really this framework has been really helpful in thinking about my work. So I'm going to advance. So reproductive justice really is a human right. It's not about access or choice. And it's really thinking about all these other areas. So contraception, comprehensive sex education, STI prevention, domestic violence assistance, all these different things that really come down hardest for cis girls of color who are system impacted. So really we need to analyze power systems, address intersecting oppressions, center the most marginalized, and join together across identities. And so if you think about the frameworks that I had laid out before, this does include applying structural intersectionality, structural competency, as well as reproductive justice. So my body, my choice really is, I'd say, the birth product of all that thought and work with my team and lived experience experts. And what we really wanted to do is think about how to address reproductive health outcomes for youth who are in the juvenile legal system. I would say, you know, I am a card-carrying child and forensic psychiatrist. I've been working in the juvenile courts really since 2007. When I finished my training at NYU, I worked in the child welfare system, actually in a children's shelter in New York City. And reproductive inequities were something that was a persistent theme that I encountered. So this work sort of is not new by any means. And just giving you kind of a shortened timeline of some of the research activities, in my role as a consulting psychiatrist to the Juvenile Mental Health Court, I would meet a lot of attorneys because I'm working as part of a multidisciplinary team, working closely with probation, judges, defense attorneys, and I would get asked to do evaluations for youth, psychiatric evaluations, to sort of situate their trauma narrative so that it could be used to mitigate the terms of probation and really explain the sort of therapeutic needs of these populations. And I became connected to something called the STAR Court, which stands for Succeeding Through Achievement Resilience. It's the first court in the country actually designed for youth who have histories of commercial sexual exploitation. And I came to learn that they had no data partner. They didn't really have ways to measure outcomes. Many court systems are pretty antiquated, so they're not really designed with thinking about data infrastructure embedded. And so Judge Pratt took a leap of faith on me and Dr. Barnard, and we started to get to work because we noticed that girls who had histories of commercial sexual exploitation were often in both systems, child welfare and juvenile legal, and they were really having really worse outcomes. And one of the things that the judge wanted to know, as well as some of the stakeholders working with these youth, is really to understand pregnancy. The specialty court really provided a range of trauma-informed, strength-based services. However, the pregnancy rates, the judge felt anecdotally were through the roof. And one of the things Dr. Barnard and I wanted to tease out as well is to really understand what are barriers and facilitators to accessing care, mental health, substance use, and reproductive health, right? What are the youth perceptions themselves, right? Very rarely do people actually ask kids what they want, how they want it, and particularly for girls who have histories of commercial sexual exploitation. Unfortunately, due to all the sort of bias, adultification bias, and racist bias gaze that we have towards this population, people really don't want to hear their opinions. They have assumption that they're difficult, that they don't want to engage. And so we really wanted to hear from them what would work. And so we did this over the course of many years, not only looking at data from the STAR Court, which was the largest court for youth experiencing commercial sexual exploitation, but also asking youth themselves about mental health, substance use, and reproductive health. And it became clear that they really wanted more interventions that were youth-centered, survivor-centered, and led. And so that's really how we got, how a psychiatrist ended up doing reproductive work. And the other thing I would say is just developmentally, if we're thinking about adolescents, and particularly those who are in the juvenile legal and child welfare system, this is when they are having early sexual debut. They are, developmentally experimenting with drugs, and those things happen together. And typically court systems and child welfare systems are often mandating treatment, right? They're mandating substance use treatment, they're mandating family treatment, mental health treatment, but they're really not touching the sex part, right? And so we see this showing up with disparate outcomes, and we really sort of need to come up with a way to increase their access. All right. And just why, girls account for 1 in 4 of the 1.1 million adolescents who are in the juvenile legal system. And their involvement is often, because of a variety of unmet mental health and substance use needs. And so we really need gender specific responses. And really not only thinking about girls who are detained, right, but just the larger population of what we call CINI youth, so court-involved, non-incarcerated youth. And just in terms of thinking about their reproductive and sexual health outcomes, girls who are in foster care, who often are also in the juvenile legal system, right? So there's this notion of these overlapping systems. They're really at high risk for having pregnancy and giving birth, early sexual debut, multiple sexual partners. Their rates of STIs are 7 times higher among adolescents versus those who are not in the juvenile legal system. And by age 19, more than half of these females have experienced a pregnancy. And I should also add that when young people experience pregnancy, whether their system impacted or not, their rates for their children also becoming in the child welfare system are higher, and even more so if they're already under surveillance from the juvenile legal and or the child welfare system. So this notion of gender injustice, right, where these youth are often coming from, they often have histories of abuse. So their number of ACEs, adverse childhood experiences, are well above the average person. And so when we think about understanding their behavior, we really need to think about it within the social and traumatic context. We tried to come up with a schema really to sort of characterize these sort of threats to well-being and really threats to their bodies, right? So in their birthing, as birthing people. So not only is there the sort of overarching abuse that they've experienced, but thinking about racism, poverty, and patriarchy and legislative regulations that really impact their ability to access care. In the US, really, again, this is just hitting home the fact that not only are foster care youth having more unintended pregnancies, but their prenatal care is limited. Their rates of low birth weight babies, higher rates of C-sections are higher. And so they're really sort of falling behind in all levels of the care continuum for reproductive and sexual health. And youth in California actually have particular barriers. So the sort of frequency of pregnancy and inaccessibility of contraception, condoms, et cetera. And so when we think about, Roe v. Wade and its impact, many of these youth do access reproductive services through organizations like Planned Parenthood. So if you're in states that are limiting those, this is going to further exacerbate that problem. This is a quote from Sarah, former foster youth, but she says, "You grow up in the foster care system with a caseworker and in a doctor's care, and you might have lots of people in your life, yet you have no idea about your own body and what you're going to experience very soon. And this is a culmination of failures within our education system and our child welfare system when it comes to sex education." And one of the things that I learned from the judges and probation officers and advocates who were working closely with these youth was that, it seemed like youth had a lot of confusion about their body, how to get, if they can get pregnant or STIs, or thinking that anal sex was safe from STIs, all these sort of distortions around even the efficacy of oral contraceptions. And a lot of that is because of their itinerant nature, the way the systems that they're involved with moves them from place to place. It causes this transience. They're not actually getting sexual education in the sufficient dose to actually make life-affirming decisions for themselves. And so how can we sort of shift that in a way that's really youth engaged. So I like this quote of all forms of inequality, right? Injustice in healthcare is the most shocking and humane. And I would say that I would argue that this injustice around reproductive health and sexual well-being for these girls is really bad in the sense that it lasts generations. And so really thinking about the needs, again, having less access, limited exposure to sex education, all of this on sort of overarching blueprint of abuse and neglect. So one thing I want to just walk you through is like how we got there, right? So we knew that at least in our STAR cohort sample that, you know, at least a third of the youth had been pregnant and 18% had multiple pregnancies. So pregnancy really needed to be at the forefront of what the court did. The court really had historically focused on mental health and substance use treatment, and then realized that they needed to get into the business of really helping youth around sexual well-being. And so they ended up hiring a public health nurse who's now part of the court team. We also wanted to hear from youth, like how do they access reproductive health care? What are facilitators and barriers? And one of the things that we learned was that they do have access, but their use was inconsistent. They had a lot of aversion towards hormonal birth control methods due to personal experiences and peer accounts. And so they're often getting information from their peers, which it's not no disrespect to the peers, but they don't necessarily have the full story. But peers are an important, credible messenger, right? So how do we sort of make sure that they have the most evidence-based information? And then just these sort of misconceptions that end up shaping their behavior. The other thing we wanted to think about is really how to frame their decision-making in a resilience-based way. So you're hearing me talk a lot about pathology and negative effects, right? But these youth are very strong. They have a lot of, I mean, we like the term fierce to really sort of recharacterize their sense of agency. So much of their agency is taken away by the systems, right? Their caseworkers shift. They get moved from one placement to the next. And how can we sort of reframe this tension between their ability to make decisions about their bodies, which is very often taken away, right, and the systems? And so we really sort of thought about this term called fierce autonomy, which really recognized their agency, and really how do you sort of work in a shared decision-making framework to sort of optimize their engagement and participation in care. The other thing I wanted to just spotlight is the sort of notion of needing more digital technologies to be leveraged in this space. So anything that any of us want to do, typically we can figure out online with our phone. But some of the very central habeas corpus issues, right, their right to the body, and when they're in child welfare, in the juvenile legal system, are not digitized. They don't have on-demand access to their information, to their treatment plan, to who's on their probation team. And so how can we sort of think about, if we sort of dream bigly and re-envision a future with more equity, digital interventions have to be closely at hand. And then this is just some of the perspectives of youth and telling us like what they wanted to have the sexual reproductive health information, and they wanted it actually in a digitized format. So they sort of said, you know, what we want, why we want, how we want it, and things to consider. And so this is sort of informed how we approach. They really wanted lived experience experts, and I can't sort of highlight that enough. And that's something I think as a resident, child fellow, and forensic fellow, I never thought about. I was just not taught that, right, as how essential people with lived experience need to be in not only our own education as we're going through our professional development, but actually as we're developing and delivering interventions. And so the youth themselves really felt like without having survivors present, it's like wouldn't resonate as much. And so situating this work also was within extant policies. So California Healthy Youth Act had passed, and also something as called SB 89. And SB 89 really recognized that youth who were in the child welfare system were having disparate reproductive health outcomes, were bearing the brunt of STIs out of all adolescents, were accounting for disproportionate share of unintended pregnancies. So they, made it that all schools would have sexual health education, right? But then there's still gaps because if you are in the child welfare system or juvenile legal system, you're often not in school for big chunks of time, or you're moving school. So we sort of felt like our intervention and partnering with probation as well as Department of Children and Family Services would offer just to fill that gap in a way. So this is how we developed My Body, My Choice. And we did it in partnership with both community-based organizations as well as public partnership. And we worked closely with a group called Los Angeles Reproductive Health Equity Project, and they had already, interestingly, had piloted an intervention called Making Proud Choices, which was developed by Loretta Jamont, and it was really designed for youth who are system impacted. However, there were a lot of limitations to that curriculum. It was not LGBTQ affirming. It didn't really have a harm reduction approach. It was not trauma informed. And so we really wanted to try to work with our youth and our partners to adapt it to make it more of those things, and also use participatory informatics, which is a way of kind of leveraging technology and having youth-centered, youth-led design in order to do so. So our version, MBMC, right, did focus on harm reduction, gender and LGBTQ inclusive. We also, because my K award, which was what funded this work, was funded by NIDA, I needed to think about substances, right? And when we asked, and some of the work that Dr. Barnett and I did in focus groups and interviews, sort of asking the youth about, do you want to hear from us about drugs and alcohol? They were really like, no, but they would tolerate sort of thinking about it in terms of its impact on affirmative consent. So we had mostly psychoeducation and wanted to talk about its impact on consent. And so that's what we did. And really our study, we launched in like during the pandemic, so 2021, 22, and we had to quickly pivot to Zoom. And people were really discouraging about this. Like, you're never going to get girls who have histories of commercial sexual exploitation to participate in a Zoom intervention. And this was actually a lot easier to do than brick and mortar. So youth really sort of liked it. So our eligibility criteria were, female youth, a cisgender female youth, 12 to 18, histories of juvenile justice or child welfare involvement, who had access to the internet and available to attend the programming. And really one of the things we noticed was that, in sort of the formative work, they really wanted graphics that were very engaging and body positive. So we really tried to take steps to make sure that our graphics really reflected that. And that's one of the benefits, I think, from partnering with them. And so youth basically completed a baseline, 1 month follow-up and 3 month follow-up. And really the testing focused on knowledge about birth control and STI prevention. How often were they using these things? How familiar were they? What was their access and availability? What were their attitudes around use, self-efficacy? So how well did they feel like they could navigate that use? And one of the things that was really important is also, given the prevalence of trauma in this population, how do they navigate sort of like My Body, My Choice type of affirming approaches to engaging in sex after trauma? So that was really key as well. These are just their gift cards. And so we do this in a multimodal way. So the way we deliver the intervention is that we use videos, we use skill building, role playing, games, there's Family Feud, there's Jeopardy. And so it's really interactive. And it's co-delivered, right, with lived experience experts and reproductive educators. This is an example of some of the slides, and really the memes that we use, they're all selected by our youth advisory board. Okay, so we had 2 rounds and we had pretty good attendance. We had a total of 37 youth. And one of the things I think was shocking to me, because I've also, bias affects everyone. And I was like, oh, I think our retention is going to be terrible. Thinking, you know, internalizing some of these same messages. And one of the things I think was really a bright spot is that really at the 3-month follow-up in our second group, we didn't lose any participants, which is really sort of remarkable. And we're in the process of writing up this work, but we had really great retention throughout the 3 rounds. And again, these kids are in group homes, they're moving all over, but they have their phone, right? And so this, when I'm talking about digital equity and thinking about how to leverage digital technologies for the most marginalized, we need the phone, because that's the one thing, you know, people are like, oh, they're under-resourced youth, they don't have a phone. They almost always have a phone. And so how do we sort of think about that? And I think that's one of the selling points, as well as the fact that we worked closely with lived experience experts to do it. This is the average age of our population was 17. Youth had either both involvement or formal involvement. 92% female, 3% non-binary, 5% skipped, and really some of the results. So you can see that these are all, let me try to move this bar. So we have a small sample size, but directionally, these are the significant, statistically significant findings, but really they're all moving in the direction that they are having more knowledge, and that knowledge is sustained over time. So they're having an increase in knowledge around different forms of birth control, understanding the use of condoms, understanding that they must take birth control every day. And so these are things that they didn't really get necessarily, right? Before even this, you know, pulling a penis out of vagina for ejaculation, many people think like the pull-out game works. Okay. So this also just shows that, you know, basically the retention of the skills that they learn at 3 months was pretty good and pretty consistent. And so one of the things I neglected to state is after the intervention, like we do the baseline and we do the intervention, and between baseline to 1 month and 1 month to 3 month, we have a digital interface for youth to get push notifications on their phone. So they're allowed to, if they want, they can opt into doing sort of quizzes that reaffirm the knowledge that they learn. Actually, a lot of youth didn't participate in that. It was kind of mixed, but there was an opportunity for them to sort of review different, you know, content related to STI prevention. But even without a lot of utilization in that area, you still retained their knowledge. And also just the mean number of correct responses, a median number of correct responses over time. So they're doing better on their assessments, and that's sustained over time as 3 months goes. Okay. And so really these are outcomes that showed improvement, increased knowledge of sexual health, health safety, positive attitudes towards condoms, you know, greater self-efficacy. And these are all things that they need to be equipped with as they navigate work. But one of the things that was really kind of concerning was this notion around anal sex. And it's something that's not, I think, openly discussed, but they're really not using protection at baseline. And that's something that hasn't changed. So we're doing version 3.0 now, we're getting ready to go in the field. We're going to really sort of focus on education of STI prevention around anal sex. So this is really, you know, notable education opportunity. Okay, and then the kids liked it. So they really felt like they found the online interface engaging. They didn't seem to mind the Zoom, even though there was concerns about Zoom fatigue, but they sort of enjoyed the content and they really liked the games. And so, you know, part of a pilot, right, you want to assess feasibility and acceptability. And this, we're successful in this area. Okay, I want to go to, these are just some of the things that they said, some of the quotes from them. And, you know, so limitations, sample size, of course, this is a pilot, right? And the goal is to scale this up. Our next round, we're going to really shoot for having at least 50 to 75 youth. really sort of thinking about Zoom fatigue. How do you sort of have standards around keeping the camera on? We're talking about really sensitive content with kids who have had histories of trauma. So there might be reasons they want to keep it off. How do you make sure to do wellness checks in terms of protecting people's well-being? So navigating all of that. And we have a high density of staff who are present, but you don't want to have too many adults in the room, even though they need to be in the room. And then their cameras are going to be, so thinking about all those sort of issues, also obtaining court permission. So that's part of the process that can be really challenging for this population, sadly. So lessons learned, youth really have to be kind of nudged. And so sort of thinking about ways to enable push notifications to remind them to show up. And also because we're working with young people also as facilitators, how do we sort of shape their professional development without our sort of heteronormative patriarchy standards around what that means to be professional, right? And so we have to sort of co-develop rules of engagement around that, making sure that we have prizes and, you know, navigating IRBs, which are not very, I think, sensitive to some of the needs of working with under-resourced populations, and this balance between sort of incentives and coercion, at least from the gaze of the IRB, right? But youth do need things, incentives to show up. Okay. So, and this is, I wanted to just spotlight this because this is the goal, right, of like engaging in this type of work, is that you're going to disseminate the findings together with the lived experience experts and the community partners. And so we really wanted to write about our adaptation process. And so we did with our lived experience expert, as well as one of our CBO members. So the fierce urgency of now, right? We are, I'd say, Roe v. Wade, the Dobbs decision, and how that impact is really impacting this population the most. And so, you know, thinking about structural competency and how to sort of work, you know, extraclinically, the policy mandate, the legislative threats to this population, that's the fierce urgency of now. And this is not new, right? So a lot of these laws that have been enacted on racialized bodies really are from a legacy of eugenics, forced birth, forced sterilization. And so when you think about some of the tenets of the reproductive justice movement, it's the right to have kids or not to have them, right? And access broadly to all forms of family planning. And so when the decision came out, a lot of us who work with this population are like, oh my God, it's going to be worse for the most marginalized. And oftentimes you don't see the face of abortion activism as being melanated at all, or also being young, but really recognize, please, how critical this is to racial injustice at large, and that the differential impact is really going to hit these populations hardest. And just, I want to just highlight, you know, that research has found that state level abortion restrictions are associated in higher rates of adverse outcomes for Black individuals, and inequities have widened in these areas and really where people are living. So 43% of women between ages 18 to 49 are living in states where abortion has or will become illegal. And so this is really impacting ethno-racially minoritized women most. And this sort of gives you a map of most restrictive policies. And it's not just restricting, you know, abortion, yes or no, right? It's restricting as well access to all the other services, and that has an impact. And the impact, you know, there's this notion of contraceptive deserts, right? So if we look at this map or this one, right, the sort of darker red, orange, you know, those are sort of contraceptive deserts where not only abortion policies are more draconian, but also access to contraceptive care. And that's where we see more needs also for women, you know, so disproportionately women in those states also have more needs because there's more concentrated poverty in those areas. And so the proliferation of these sort of contraception deserts is worsened by policies enacted under the Trump Pence administration. And the downward effects of these are multimodal. They're life lasting because not only does it impact prenatal care, it impacts pregnancy related complications. It impacts maternal mortality, which we know is a public health issue for Black women. It also impacts infant mortality, and there's this notion of policing the womb. And so the people who get in trouble for having a miscarriage, how that's policed or criminalized, that's also disproportionately on Black and brown women. One of my colleagues and I, we wanted to sort of implore child psychiatrists and child mental health professionals to care about this, because we are seeing kids and treating them for trauma and substance use. And so we also need to be thinking about their access, not only sort of in the clinical space, right, but sort of extra clinically as well. So we wanted to capture that. And then just in terms of thinking about future directions, really sort of moving from community-based participatory research to community participatory research, and then youth participatory action research and structural competency. So I want to do like a massive mashup and really have youth actually involved at the policy level and thinking about, sort of co-creating digitally equitable, youth-centered, youth-developed design and youth-led, and making sure that that's anchored within social justice advocacy. And that's it.
Thank you so much. That was wonderful. Let's see, how do we navigate? Is there questions from the Zoom folks? And then people here, if you have thoughts or questions for Dr. Bath, I think there's a box that's a microphone, so you can feel free to chime in. Anybody here? Okay, go ahead.
Thanks. This is great, Dr. Bath. You talked a couple of times about participatory informatics, and I'm really curious if you could speak more about those, and then about any like key or unique insights gained by using those particular types of informatics, because I think that'll be the key to the work if you're doing participatory action research.
Yeah, so a colleague, Armin Arabian, who used to be a UCLA faculty member, he co-developed that, and it was really to apply community-based participatory frames with digital innovation, right? And so really having the community members design the app themselves. And he's partnered with a lot of different investigators locally and nationally. And so we reached out to him for this. And so we, did engage in that process where the end user, right, the youth should have the most say, right? Nothing about us without us. And so really trying to anchor that premise. And so in the interface that the youth have, so the text messages, the type of memes, GIFs, all of that is how we use that framework to make sure that the youth sort of like the content, the frequency of when people get push notifications, like, do they want to do something called ecological momentary assessment or not? But making sure that we're thinking about not only how the content is delivered, but when. That there's a lot of different considerations, but making sure that they're actually in the room sort of building that. And so it's really, it's super cool.
Okay, thank you. I just want to check whether there were any interventions between baseline and the 1 month and 2 months follow-up, looking at the behavior change from the results that you presented. Thank you.
Do you mind repeating the question? Just make sure I understand.
Okay, I just want to check whether there were any educational interventions in between from baseline, 1 month follow-up and 2 month follow-up, looking at the behavior change from the participants.
Yes, so should I go, maybe I can go back to that slide. So you want to understand between 1 month, 3 months, the different behavioral changes? Yeah, I mean, let me see if I can go. in terms of understanding concepts. Okay. So, and your question was specifically around, understanding concepts around birth control, methods, right? So, we did see, and these are the statistically significant areas are in yellow. And so one of the things that at baseline, and even that we just knew from, working with probation, reproductive health counselors, is that youth have a lot of confusion and myths around particularly hormonal contraception. And so that appears to be increased because they just really haven't had access, I think, to that education in a way that they're getting all of the modules, right? So even though there's a law SB 89 where they're supposed to get it in school, they may switch schools or not be in school. And so this is showing increase and improvement in that area. Even learning about what is an IUD, right? Oftentimes that was one of their sort of first exposures. And so this one actually, so it's confusing because it shows that the number of youth who didn't, who responded slightly familiar or not familiar at all actually goes down, which we want. So we want more familiarity with these methods to be happening over time. So there are less youth who are not familiar. Does that make sense? So, okay.
Great, thank you so much. So, Dr. Beth, there's one question from the Zoom. It says, thanks, Dr. Beth. Is CTSI, and maybe this is a question for Lucy and others too. So is CTSI currently seeking support for outreach? I'm currently a research volunteer at UCLA who is passionate about CTSI's social equity mission after being a journalist in South LA and East LA.
Yeah, that would be awesome. I can definitely reach out to her.
Okay, great.
Thank you so much.
I would love CTSI to help me. Sorry.
Yeah. Yeah, thank you. Thank you so much, Eraka. So I know that we're almost out of time and we still have some folks on Zoom on our webinar. Again, I always learn something new from you, and I'm really intrigued by your future directions in terms of, so my body, my choice, you're thinking about like the version 3. And one thing that's really struck me was this might be a way to kind of enhance and advance the sense of belonging with youth. And I know that the initial intervention that you adapted was, facilitated by experts with lived experience. So my immediate thought was the youth who participated in the intervention for version 3. I wanted to ask your thoughts about possibly kind of mentoring them up for them to be able to be the champion of providing the intervention to their peers. And on top of that, sort of looking at, instead of doing the modules with fidelity, maybe kind of honing in on some of those modules that have a really significant impact on some of those outcomes. So it's not exactly like the original My Body, My Choice, but kind of training them, the participants for the next version 3, to kind of focus on, for example, the education about the harmfulness of anal sex, for example.
Unprotected anal
Yeah,
sex.
yeah.
No, I think you're exact. I mean, and that is really what does the community need the most, right? So is that what that result, for example, is showing us? That's one of the areas, and making sure that we make adaptations accordingly. And I would say that there is a precedent within the community of youth who experience commercial sexual exploitation to actually have survivor leaders. So many times youth who've had that experience end up getting multimodal treatment. And then part of that treatment includes mentorship, professional development. So they end up being able to be leaders. And so, yes, we would like to build that same, pathway, if you will. And we did call, so our lived experience experts were survivor leaders who sort of came up through the LA County juvenile legal and child welfare system and were recognized by one of our community partners, Saving Innocence, as having promise. And so part of what, the professionalization, like we give them a certificate, it's something they can put on their resume. They also get a designated sex educator completion. And so making sure that we do that for the graduates, I think is a wonderful idea.
Yeah.
Yeah.
Yeah. Well, thank you so much.